I'm now currently more running an open science platform, a design platform called SciNFT. The goal is nobody should ever send a paper anywhere. So I hope next year nobody will talk about their paper in Nature Communication or whatever. On our platform, you publish anything in 2 minutes, including a figure, a negative result, an ID, a question, and we really want to change the paradigm of publishing. I'm exhausted of this, so it's really a disclaimer, and we will be inviting everybody to post their presentation as PowerPoint so other educators can use the slides and share more and more. So I'm happy to talk about that, and I'm doing research at Sidra Hospital in Doha right now, a lot around genetics and PRS and how we can use like screening of large cohorts to tailor therapy. So I knew it was not a cancer crowd, so I'm more gonna just depict few things that have majorly changed the way we treat some cancers over the last few years, and kind of like open discussion for what the future. So endometrial cancer was something that endometrial cancer was something that was very homogeneous when I started medicine. Endometrial cancer, basically obese patient, high exposure to estrogen after menopause due to obesity, and everybody was treated the same. And the crazy thing, a TCGA study came out, one of the first TCGA study, and showed that actually endometrial cancer are very different, like huge differences in phenotype, and the TCGA pointed out very, very major differences in prognosis, and I'll show you that. And it literally took 15 years to Gynom to take upon that paper and start stratifying patients and treating them differently. And that's really like from 2-3 years ago. And so that gap is really humongous. The gap between basic research lab and clinicians now is widening because there's more and more research published every day. Clinicians don't have time to read. And I think that, AthenaDAO, by bringing clinicians, entrepreneurs, and people in the same room will like contribute to close that gap. So now endometrial cancer is basically 4 diseases. The tall mutation is people that have a lot of mutation, like very high mutational burden in their tumor and are extremely doing well. These tumors are not aggressive. You could even avoid treating them. Most people will not die out of it. And then on the other side of the spectrum, and I don't want to go into details, you have the P53 that look really like an ovarian cancer kind of thingy. It's like ovarian cancer, gastric cancer, P53 mediated, and the patient do very poorly. And this is just to show you how the prognosis looks like. And so you see tall people almost don't die. Progression-free survival is 0. So even maybe an aging phenomenon rather than a cancer, if we can call it this way. And the people that have a P53 mutation have a very poor prognosis, very close to ovarian cancer. And so now the standard of treatment in endometrial cancer is extremely conservative for the patients that have good prognosis and extremely aggressive for the patients that have a poor prognosis. And that's been the major change that we see is stratifying patients by genetic profile. And I do think that a lot of it could actually convert into ovarian aging, early menopause, all of these things, because my best fertility friends tell me, Mullerian hormone or count of follicles is not a good predictor of ovarian failure. Maybe if you throw in genetics or like whole genome sequencing for patients, you could start stratifying patients and act on the one that needs something. The other thing that really is growing in endometrial cancer is combined therapy. So oncology is completely changing now to the extent that we don't even know what to treat. I have no brain potential to learn all the new treatments that are coming out. And right now, the new trend in endometrial cancer is really to use multiple pathways, blockade, to treat ovarian cancer. So the anti-angiogenic drugs have been they're around, but now they're really increasing, and now we're not targeting anymore VEGFR, but VEGFR, FGF, multiple molecules at the same time, and we're combining that with anti-PD-L1, so immunotherapy, that activates your immune system, and we already see, so these are patients that have advanced endometrial carcinoma, so recurrent, that are resistant to carboplatin and Taxol, and already there's a huge gap in PFS. And so what we're seeing now is a lot of cancer patients are becoming chronic patients. Like some of my patients, I tell them it would have been worse if I tell you you got diabetes, because we have so much drugs that we're going to just keep on like prolonging your, you're going to have some residual disease, but it doesn't matter. You're going to be fine, you're going to be functioning, you're going to have a normal life. You're just going to be on a drug for a long, long time. So really we're like becoming chronic patients. And that's like overall survival of combination therapy. 14 months is amazing. And now also something that happened is there's so many drugs coming out that if you get 14 months more survival, you can benefit from a new line of therapy that was not even there or that was not approved. So it becomes like crazy of patients how jump from one to the other one. And one of the things we want to really work on is basically exceptional responders who are suddenly you have a patient who has a 100% response to any drug, and what we call N of 1, each patient becomes a study right now. And all the major oncology studies are becoming obsolete because patients need to be way more stratified than before, and for one patient, one therapy could suddenly work, and we don't really understand why. And with that comes like this issue of if you live longer, how are you going to live now? And that's becoming a major now issue in oncology care is patients are not complaining about the tumor, but they're complaining about the diarrhea, the lack of libido, or whatever. And so now I think there's need to be a peculiar attention on quality of life metrics, quality of life management as early as possible, so basically at diagnosis, and probably find some technological solution to help the patients, like, I don't know, follow-up, wearables, etc., that need to be created to get quality of life part of the care and not something that we do offer on the side. So it's really optimizing, etc. Cervical cancer is a very good example of a dogma that was actually defended in the classical publishing system for years, which is extensive surgery, remove all the lymph nodes, do the parametrial dissection, with very heavy consequences for the woman in terms of bladder, sexual dysfunction, etc. And that's an example of like amazing change of paradigm. So some people started doing normal hysterectomy for the small cervical tumor, and they actually saw that there absolutely no difference in survival between patients that go radical hysterectomy, which has a lot of like side effects, compared to simple hysterectomy. And that resulted in this, which is basically preserving fertility, which was a major challenge for patients having early cervical cancer around 30 to 35. We do think that smoking is a heavy factor for this patient to have, I don't know why, we find this young patient that have like pre-cancer, evolved through cancer very early if they're heavy smokers. And now we changed basically from this major surgery that was removing everything to a simple resection, and for most early stage tumor, that's completely now preserves fertility and it's very respectful of the woman's body. There are production results of the biggest trial, which is called SHAPE and run by Marie Plante in Montreal, in Quebec. It's going to come out soon. But I mean, you know, fertility is preserved. People have C-section, a little bit more premature birth, but you know, really like game changer for the patient in that field. And then also the immunoevasion. I'm not going to go into details, but cervical cancer we know it's really a disease of responding to HPV, so the immune system is very important, and that's the latest trial that's been using immunotherapy in this patient, and you can see the curves are diverging crazy. And now we're going to do multimodal immunotherapy in this patient, and probably we're going to like kind of like break the ceiling of that curve and like get patients to have chronic disease. It's a very devastating disease because the polyps, etc., etc. So I'm really looking forward to the progress that we can make. If we can like kind of get to the place where people in melanoma care are, that would be really amazing for this patient. That's overall survival, and you see how the benefit is already huge at that 5 years follow-up. It's really crazy, like 49 to 61% at median. It's really amazing. In ovarian cancer, the most significant discovery that were done is basically the discovery of the role of BRCA or HRD, like the lack of homologous recombination in patient, and the discovery that these patients are absolutely sensitive to PARP inhibitors. So I don't know if you guys are familiar, but the PARP, the BRCA system serves to repair double-strand DNA breaks, and patients that have BRCAness are not able to do that, and they go through PARP. And if you need PARP pathway, you induce more DNA damage, and then that results in HRD. The interesting part is that so most of the ovarian cancer have a BRCAness that's positive, some don't. We don't really understand the difference between these two. BRCA is not the only predictor of BRCAness. There's also a lot of genes, and there's some kind of a global HRD that these patients have outside of any known mutation that we know. But basically, I can show you 100 studies like that now. It's insane, the difference between any PARP inhibitors and placebo or classical chemo. I mean, you see like survival curve going from like at 2 years almost nothing, 10% to more than 50%. Like that's really tremendous impact. I mean, that had on ovarian cancer, and really ovarian cancer is becoming a chronic disease for the patient that respond to PARP inhibitors. It's really insane. It's really the impact of this drug, and the understanding of the biology of it is still unknown. The interesting part is that a lot of the patients that don't even really have obvious BRCA still respond. So is that tumor heterogeneity or stuff like that? We don't really know. And in conclusion, because I wanted to keep it short for discussion, better understanding of the biology really changed the picture. You know, we went from super surgical-driven management of cancer to basically listening to the biologist in the lab who says, hey guys, like, you know, like maybe you didn't get it right, and that really is has been the most impactful thing in my practice. Less aggressive management is really the trend we're going. We're trying to do less and less and less, and desescalate everything. Less chemo, less surgeries. You know, people are doing now microdose of chemo on the long term, like Taxol microdose for very long term for ovarian cancer. That's working. And most of gynecological cancer are becoming chronic disease. And I hope, like in 5-6 years, there will be no difference between diabetes and ovarian cancer, etc., etc. We do need more N-of-1 therapy. We do think that I think that there will be a huge benefit of having a real-life data set where patients populated. The doctors can't follow up anymore. Patients have long-term disease. 5 years is anymore nothing. No institution has the money and funding to follow up people over 10 years. And you need patients to give you info. You know, you need to say that I'm doing well, I moved and I recurred and I got this treatment. So there's going to be a huge need for digital databases where patients populate their data and they say, oh, this is my therapy, I changed the doctor, I got this, because you lose them. You just lose the patient and you don't have the data, and I think there's going to be so much collective intelligence coming out of it. And I do also think I'm really very keen on quality of life, as we got it. I think it's very important. Usually quality of life is after treatment. You know, we get a patient and we tell them after that you can see a psychologist, you do your physical therapy. I created a foundation when we brought patients at diagnosis to mountaineer. So we did like high altitude mountaineering with patients, with cancer patients, and the specific recruitment of the patients were if you have chemo, you have to be in chemo or start surgery. And tremendously changes their life. To see that they still own their body, that they still have ownership of their body, tremendously change their life, tremendously change the way they approach treatment in terms of going to do stuff and, you know, being more active on a daily basis, not passive in front of the disease. And for some of them, it really changed at least a psychological outcome, less depression, more, you know, sexual life, etc., etc. And all of this is really important of I think the caring process. I think there's a professor in Stanford, I always forget his name, but forgive me for that, who did an amazing TED talk about healing versus caring. And he really comes about like most doctors just care for their patients, but very few of them try to heal them. And I think that we should really revisit that paradigm and try to understand, you know, what is the need of a woman or a man as a patient when we announce them something. When you go to an ART process, what part of your well-being is going to also be of concern, or rather than just dumping hormones into you to get you a baby? I think these are very important questions that we have to answer as a community. Thank you very much.